Well, good morning, Dr. Stayner. Good morning, Colin. Thank you both for joining us today. Really looking forward to talking about your abstract you presented at ASPN with Minuteman and spinal cord stimulation. I want to, if you would be open to this, Dr. Stayner, just to start with a little bit of who you are and your journey. I know it's a little bit unique where you took a couple years before you even started to get into the medical field, traveled a bit, learned Japanese, and I just think that's super interesting. So if you don't mind just sharing a little bit about your journey and what led you to interventional pain management where you are today.
Yeah, so I started out in my undergraduate college career wanting to go to medical school and was pursuing a degree in biology. After the first year of college, I spent a couple years in Japan just doing volunteer work for my church, and I picked up Japanese, learned spoken Japanese, and after I returned back to college at the age of 21, I switched to engineering because one of my friends just suggested it as maybe an alternative to doing biology. And at the same time, I just started studying Japanese formally and eventually got a bachelor's degree in Japanese, but had the opportunity to go to Japan and do research both in my undergraduate degree and then after undergrad, instead of going to medical school, I found that engineering was interesting. So I matriculated in a PhD bioengineering program and spent 5 years basically studying biomaterials. That was my emphasis, and found that to be interesting. But I missed interacting with patients. Working at the bench is a little bit isolating, and I kind of jokingly, but it's half true, I always felt like I would rather be in front of patients using technology that other people had developed, and getting sort of that direct feedback from patients about how things are working rather than being behind the scenes all the time. So instead of doing a postdoctoral time, as most PhD students do, I decided to enroll in medical school. So I went to medical school instead of doing a postdoc. And then the pathway to interventional pain, that was also a little bit convoluted, but for residency, I decided to do anesthesia, just partly because I was fascinated by that anesthesia machine. It's very complicated, and I thought the engineers who did that did a great job, and I was very impressed with it. But as part of the anesthesia rotations, as a resident, you're required to do a rotation in pain medicine. And most people sort of see that as a somewhat of a punishment because you often go into anesthesia, so you have less patient interaction. But in my rotation, as I was visiting with patients, many of them were reminiscent of my own grandmother who had significant chronic pain issues. And a lot of the treatments that were offered to these patients, I wished had been available to my grandmother who had been escalated on high doses of opioids after multiple back surgeries that were quite invasive. And so I decided to do a fellowship in pain medicine, and found it to be very, very enjoyable. And I've been working as a pain physician since about 2012. I would say since the time I finished fellowship until this point in time, the field of pain medicine has progressed from us as pain physicians simply providing things like steroid injections that are not really meant or can't really provide ongoing relief because they don't really address structural pain issues, to now us being able to do minimally invasive treatments that can actually address structural issues that are causing patients pain. And I was introduced to the Minuteman device in 2020, and I thought it's from an engineering standpoint, I thought, geez, this is just such an elegant device. I wish I had invented it. and the engineers who are behind the scenes that develop this technology, so that a pain physician who has very good hands and very good understanding of radiographic imaging uh, can provide an alternative to patients who are either not candidates for a traditional spine surgery because they have too many health issues and would not be able to maybe even survive or recover from a spine surgery, or there are patients who the structural issues that are causing their pain are maybe not so significant that even a spine surgeon would even attempt to address them, because the recovery and the surgery itself might cause more complications than it would help. But with the Minuteman device, we can address those, maybe those structural pain generators in a minimally invasive way, and in a more permanent way than we could with our injections, and not subject the patients to, the huge spine surgeries that they may not need and may not benefit from.
Well, that's fantastic, Dr. Stayner. I love your background and passion for technology and engineering, and how that's even led you to, the different therapies you might be looking at or choosing today. That's just such a unique connection for even some of the pain doctors who I've had the privilege of getting to know. And so that kind of is a good segue into, the premise behind you kind of looking back at the patients that have had Minuteman and then also had spinal cord stimulation. So what motivated you to look back and go, okay, I want to take a look at these patients, write an abstract, and then present this at ASPN? What was your thought process there?
Spinal cord stimulation is something that's very familiar to most pain physicians who have been trained within the past maybe 15 to 10 to 15 years. It's a tool in our box that we use routinely, especially for patients who have um, had a spine surgery and still have persistent pain. We term that post-laminectomy syndrome. And with Minuteman coming on the scene and some of the other minimally invasive procedures that we can address structural issues, I wanted to see how this new technology fit in with the established procedures and technology that we have offered to our patients traditionally. And so, since we had a cohort of maybe, I think, 106, 110 patients, or at least 110 procedures, Minuteman procedures that we had done, I wanted to go back and look at the ones who also had a spinal cord stimulator, and just compare patients who had the Minuteman without a spinal cord stimulator to those who had a spinal cord stimulator and the Minuteman device. And I guess anecdotally, I've heard from patients who I've treated with Minuteman and have a spinal cord stimulator implanted already, that they tell me they feel like their spinal cord stimulator works better. And there's one patient in particular that comes to mind. He had a spinal cord stimulator for low back and a lot of foot pain, and spinal cord stimulation is great for neuropathic pain. But he also had spinal stenosis, and he was constantly having to have his spinal cord stimulator adjusted. And as we see sometimes with spinal cord stimulation, the trial works really well, and then patients, for whatever reason, sometimes can become tolerant, become tolerant to the stimulation, and they just don't feel like it works as well as it did in the trial or when it was initially implanted. So anyway, I went in to follow up with this patient, and I asked him how he was doing, and I expected him to tell me the things I would expect for resolution of symptoms from spinal stenosis, like, it's easier for me to walk upright and things like that. And what he told me was, man, my feet feel so much better. It's just like my stimulator's working. And I thought, well, that's really interesting. But it makes a lot of sense, because we had addressed with the Minuteman device a structural mechanical issue that spinal cord stimulators are not very good at helping with. In some ways, pain physicians are thinking, or I was thinking initially when this Minuteman device was introduced to me, that patients are in either box. They have some sort of spinal stenosis or instability, and that can be helped with Minuteman, or they have neuropathic type pain with burning, tingling, numbness, and that can be addressed more efficiently with spinal cord stimulation. But what we find is that many patients have both types of pain. And so we just wanted to, in a real world setting with real patients, and so these are kind of, we get the patients that a lot of other pain physicians and spine surgeons just can't or won't treat because they're complicated. So we just wanted to look at the patients that we've treated and just see how spinal cord stimulation and the Minuteman device work together.
I love that dual therapy approach. It's unique, and it's something that, I personally haven't seen in the space too often, addressing the neuropathic, biomechanical at the same time with dual therapies. That's why I was so interested in talking to you both about this abstract, because of that premise that you both had there. So let's get into a little bit of the results. So you said about 100 or 103 patients or so, or at least levels. What did you find as you analyzed the dual therapies, and how their functional outcomes improved, how their pain improved? Maybe Colin, you could talk to this as well, but either one of you, how did you analyze those outcomes?
Colin, I have to thank for this because he's our data guy, and he kind of took the research concept that I presented and went and dug into the patient charts and found, looked at our EQ5D data and our disability data and really crunched the numbers and tried to make some sense of what we were seeing. But the general gestalt, the bird's eye view, is that it seems that the Minuteman device was better for helping patients improve with functional outcomes, but maybe not as much with pain, ironically. So certainly people say that they got pain relief, but it was more functional outcomes that we saw. Now, patients who had a spinal cord stimulator and the Minuteman device, they tended to report better pain relief with the dual therapy. So that also kind of helps you set expectations for your patients when you use either system or when you're using a combination. And so with Minuteman, I'm now coaching patients that what we're really looking for is increase in function, especially when you're up and walking. But if they still have pain after we've placed a Minuteman device, there's another therapy that we have that can help augment their actual perception of pain. Would you agree with that, Colin?
Yes, I would, doctor. And just a quick correction about our cohort size. We had a total population of 57 in this analysis. So I believe our total population that at the time of analysis, Dr. Stayner had performed procedures on was around that 114 mark, but we only had available follow-up data for about that 57. And moving forward, since we're following up with these patients still, we should hopefully have more follow-up data on those patients which were not previously included.
Yeah, I love that. So one of our core values here at Spinal Simplicity is patient first. And so what I love about this, guys, is you're looking at functional outcomes and pain in your patients and how they're improving. And your abstract talks to that very well. So thank you for sharing that, both of you. I'd like to know, and maybe this wasn't included in the abstract, maybe it's anecdotal, but have you guys seen any clinical evidence, or maybe even just talking to patients? They come in, maybe they're using opioids, and they either get a Minuteman or a Minuteman plus spinal cord stimulation. Have either of these therapies helped your patients maybe taper off of that? I know we see this quite often because Dr. Stayner, as you mentioned, we're addressing the biomechanical instability in the spine. And so the long-term effects of that is hopefully our patients are able to reduce their opioid use. Have either of you guys seen that in your practice? Is that one of your goals? Maybe speak to that a little bit if you can.
We're sort of at this point where we tell patients, we'll give you this much opioid and we really can't escalate any higher. And there's a lot of discussion about whether that's the right or the wrong thing to do. But pain physicians are really scrutinized these days and judged in not only the public opinion, but by regulatory agencies on how much opioid you're using to manage patients' pain. So the nice thing about having a Minuteman device or the spinal cord stimulator is that you can tell your patients, this is kind of the threshold of opiates that's considered, at least in our area, standard of care. And if we go beyond this, we can justify it. But if we do it too frequently, we're going to be scrutinized, which we don't like. But we have other options to address structural pain so that you don't need as much opioid to manage your pain or to be functional. So that would be another study that we'd love to look at. We haven't looked at it formally, but anecdotally, patients just tend to not need as much opioid medication when we can address structural issues.
Yeah, no doubt. I think we're seeing that across the country, that philosophy, and it can be a conversation for sure. But that's one thing that we're hoping with the Minuteman is we can, fix those biomechanical issues in the spine, and hopefully those patients will be able to taper off some of those opioids if that's the doctor's desire there. So,
and I guess the other thing, the shift that has occurred within the past 5 years is that, again, I talked to you about my grandmother's experience this was back in like 1999, 2000. And this was just at the height of the opioid epidemic, or when it was not the height of it, but when it was ramping up. And there was a shift in opinion regarding use of opioids, that instead of using them sparingly, we would treat chronic pain with opioid medications because we were doing the right thing for the patient. We shouldn't be as worried about addiction and dependence and all other side effects. We should be treating pain. That resulted in some significant problems. It's been termed the opioid epidemic, and we've seen issues with both prescribed and non-prescribed or recreational opioids, causing significant harm and even death in patients in the pain population. But the shift has now kind of gone back to being very opioid sparing. And so we're now getting patients who have mechanical pain issues, but are not escalated on high doses of opioids, which is actually a good thing for us, because we can start to address those mechanical pain issues, again, in minimally invasive ways before they're escalated on high doses of opioids. Once they get on high doses of opioids, the opioid use becomes its own entity and its own issue in some ways. But we're able to intervene, again, with minimally invasive treatments before opioids are escalated, and we're able to maybe address both issues. We're able to address pain and function, but also keep opioids at reasonable doses so that we don't end up with patients who are on high doses and at risk of either overdose or diversion or dependence, all these other things that have been problems in the past.
Yeah, well said. And that leads me to my next question here, my last one. I'd like to hear a little bit about how Nura Precision Pain, Dr. Stayner, how you guys are addressing and thinking about, as interventional pain management doctors, our population is obviously aging at a more rapid pace than it has in the past. And I've read some statistics like in 2030, we're going to have, more people over 65 than we do that are 13 for the first time, maybe in a long time. And so as you're thinking about like this population aging, with these different therapies you have to offer your patients, what are you doing like to prepare for, I guess, if you could do anything, like more patients that are going to be needing the therapies that you offer?
In context with the Minuteman device and Spinal Simplicity, again, we have something that is less invasive that can still address mechanical pain. For patients who have significant spine issues, Minuteman device may not be what they need. It's not to say we don't need traditional spine surgery. It's just that up until now, we've had just one tool to treat everything. If we can address smaller mechanical issues earlier on, they may not escalate to larger issues that require larger interventions. We're living longer and we're working longer. And I think that's just a trend that we're going to see in the future. So we need to be functional longer. People expect to be active and working or playing hard or having nice recreation well into their 80s. And with a combination of spinal cord stimulation, And the Minuteman device, we can keep people active, they don't have to be laid up in the hospital for days with months and months of recovery in order to just get back to normal functioning.
I love that. Well, is there anything else about your abstract that we haven't discussed today, guys, that either of you would like to add?
I'd say from a study design standpoint, it would be great if we had a huge clinical trial, and those are a randomized control trial is kind of considered the standard, if you will. You don't practice in the same setting that you would conduct a randomized control trial. I'd love everything to be in a nice little box, and I could just say the p-values for every score was significant. But I think what we have demonstrated is at least the trends seem to indicate that the combination of Minuteman and spinal cord stimulation, if Minuteman isn't enough, or on the other hand, if spinal cord stimulation, if people are tolerant to that therapy, maybe going back and looking to see if there's spinal stenosis and treating them with a Minuteman, the combination of the two provides better functional and pain outcomes than perhaps either one by themselves.
Well, thank you, Dr. Stayner, for that answer. Colin, I want to switch over to you real quick. I know that you spent a lot of time on the actual data on this abstract. So if you want to speak a minute or two about the analysis of the data and the outcomes specifically, I'd love to hear more about that.
Yes, I'd be more than happy to share. One of the challenges that we kind of did face with this data set is turning it into something meaningful and understandable. So we did a post hoc analysis on the data gestalt that was originally developed by all of this, and turning a large data set into something meaningful takes a lot of cognitive effort, and doubly so because this was not a randomized control trial. So this was real world application. So the data had a lot of noise. It was quite messy. So one of the things that we actually noticed was that there was oftentimes improvement in overall functionality as determined by the EQ5D or ODI. But if we looked at the ordinal scale of improvement, the data wasn't standing out. So one of the things that we did was transitioned the data set from ordinal to categorical. So basically, instead of saying, did they improve by this much percentage, we just asked, did they improve at all over several categories on these different questionnaires. And that's where we were able to see the most difference and where we got a lot of our significant values, save for some of the EQ5D, which again are measuring the impact of pain on quality of life. So with the ODI, that one in particular, so that was one thing that, I was working with Dr. Stayner to determine how exactly we were going to measure it through the body of literature which exists on this questionnaire. It was determined that it was probably the best tool that we have available to determine if there was functional improvement. And we saw that, as you can see on the graph, both groups were similar. And that's kind of how we arrived at the conclusion that the Minuteman is what helps improve functional outcomes. When we start looking at like ODI, which bears on the impact of chronic pain on those everyday activities, that's where we kind of saw the difference or the suspected benefit from the spinal cord stimulator.
Well said. Dr. Stayner, Colin, really appreciate your time this morning. Thanks for taking time out of your busy day to join me. Love that you're, again, like I mentioned earlier, thinking so much about your patients, not only treating them, but then looking back on, oh, is this actually working? And we're, based on your abstract, it absolutely is Minuteman, but then also Minuteman plus spinal cord stimulation. So I appreciate your work in helping the patients up in Minneapolis. Thank you guys for joining me today.
All right. Thanks for your time.
Thank you.